typically in breast cancer, when you're talking about high risk, is patients who have they have a previous breast cancer, or their families, the mother, auntie, or somebody very close in first line, second line relatives have had cancer before they reach their menopause. Like if your mother had cancer at 36 or 40, then you need to go to start magnetic resonance imaging or screening at the age of 30, 10 years before your mother or your auntie got it. Those are the high risk patients.
People.
Or people who have had radiation in the neck, maybe for thyroid cancer or any other issues like Hodgkin's lymphoma, radiation in the neck and the chest, they also are at a high risk of developing breast cancer.
All right. Now, the other question is, if a lady who is at 20 years of age was found to have a mass, a lump in the breast, and it was found not to be cancerous, do they need to still be screening?
Yeah, so if the lump is a fibroadenoma, which is common at that age, or just a cyst, or those cysts are common beyond 30 years, then they can be followed up with an ultrasound, if it's less than 2 centimeters, to see how it's responding with light every 6 months.
All right.
Just to check.
Great.
Some fibroadenomas may change if their size becomes bigger. And also we have another kind of, not really breast lump as such, but they come from the supporting stuff, the stroma of the breast. They're called phylloides tumors. So those can be challenging, and also they are common in younger age group because they are either benign, borderline, or malignant. So those needs to be followed up and dealt with.
All right, allow us to move to the next discussion about treatment options for the interest of time. You know, we have talked about the people at risk, how we can screen and all these things. Now, if somebody is found to be having a breast cancer, either it's early or advanced, what are some of the treatment options, especially in our context in Kenya?
Yeah, so after you've done the triple assessment, and what is triple assessment? You have clinical found there's a lump. You think it's suspicious because it's not moving, it's looking like it's retracting the skin or something. The next thing is to image. So you do your mammogram, now not screening now, diagnostic.
Diagnostic, yes.
Or ultrasound. And then you find that it has features of malignance, suggestive of malignance. Then you take the patient to the third and final stage, which is core biopsy, ultrasound guided core biopsy, so that you can take the tissue now to the lab, and the pathology people are the ones going to look at it and tell you this is cancer or not cancer. And then the biopsy part is when a piece of flesh is removed, for the sake of the viewer. Yes.
The piece of flesh is removed.
Yes.
A tiny bit.
Yes.
Is taken to the lab for now
analysis to confirm that what I've felt and what I've seen on the images is now confirmed as cancer or not cancer.
Yes.
So the other tests are done on that, apart from just looking at saying it's cancer. We call them immunohistochemistry.
Yes.
To see whether this cancer is receptor positive for estrogen, progesterone, or what we call the epidermal growth factor, or the skin factor, HER2. Why is it so? Because that gives guidance, particularly to medical oncologists, in terms of how they are going to treat them later. Yeah, because if it is hormone receptor positive, it's friendly, is easier to deal with. If it is triple negative, or it doesn't have any of those hormones, it's very aggressive. Usually in young people, it require even maybe chemotherapy upfront before surgery. So that subgrouping based on receptors is very, very crucial for us. So that core biopsy gives us information and confirms cancer, but also gives us the subtype. Because cancer is divided into 4 subtypes. It's not just breast cancer. And that then guides what treatment you're going to give. So now, once you've made the diagnosis of breast cancer, now you want to stage, because the patient will ask you.
Yes.
And patients always confuse grade and stage. Because at pathology, they'll say this grade 1 or grade 2 or grade 3. But that is in terms of cell relationship with the original cell. But staging is to say, if the cancer is in the breast, is it just confined to the breast?
In the breast only?
Has it gone to the lymph nodes? Or has it gone somewhere else? Because that determines. Or is it still in the ducts? So there's what we call stage 0. Stage 0 is when cancer is confined to where it started, either in the lobules or in the ducts. We call it DCIS. That's stage 0. it has the best outcome and is normally found on screening, not when the patient
when
is
it's
present.
found early.
Yeah.
It's not.
Yes.
Okay.
Stage 0, almost 100% survival in 10 years. Then there's stage 1. Stage 1 means is less than 2 centimeters and is confined on the breast.
The breast, okay.
Stage 2 is when it's more than 2 centimeters, or when it has moved to the lymph nodes on the same side.
On the armpits.
Yes, the same side, but the lymph nodes are mobile. They are not stuck together. They're not mattered. Okay. Stage 3 is when the tumor has involved the skin or the muscle, and it has more nodes that are involved.
Okay, yes.
It goes up to also the supraclavicular nodes, which is stage 3C. That means now the disease is advancing, but it has not escaped. It has not left the lymphatics to go to the liver, the bone, the brain, or the skeleton. Okay. And that's called stage 4.
Stage 4, now you are into other organs.
Yes.
All right.
It has moved through blood and lymphatics to other organs.
So the common organs where the breast cancer goes into?
So the breast cancer loves the bone. So it will first go to the ribs, most of the time. Ribs and then the spine.
Yes.
And it can go also in the longer bones like the femur. The second favorable place is the lungs. And the third favorable is the liver.
Okay.
Occasionally, the worst, of course, is going to the brain. When you have mets in the brain, it's very difficult to treat.
Yes.
So when you look at visceral mets and non-visceral mets, like bone mets, even if it's stage 4, the outcomes are better than when you have mets in the lungs or in the liver or in the brain.
Wow.
Yeah, so even stage 4, you can divide it into several groups. Yeah.
So to summarize for the interest of time, so how advanced, what you call the stage of breast cancer, is very important to know because it determines the treatment type
and the outcome.
The outcome,
yes,
of the treatment.
Particularly the outcome, the prognosis.
Outcome.
Yes.
All right.
So for early breast cancer, stage 0 and stage 1, the upfront treatment is surgery.
Surgery.
We want to remove that cancer from the patient.
Yes.
Okay.
Yeah.
So what do we do? Usually, we have 2 options. If the cancer is small, we just remove that lump. It's called breast conservation surgery. I started here in this region in 2008. You remove the cancer plus a rim of normal tissue so that there's no cancer cells remaining. You also assess the lymph nodes. By not taking the axillary dissection, all of them, you take just a few, we call it sentinel lymph node biopsy. Then you take them to the lab. Usually when you don't remove the breast, to avoid recurrence and improve outcome, you have to associate again after healing with radiation. So you have to do radiation therapy. Yeah. But before you go to all this, treatment of breast cancer is teamwork.
Yes.
It's called multidisciplinary approach.
It's not one specialist.
Yeah, it's not Wasike deciding for the patient everything, because different patients at age group and subtype of cancer require different treatment. So the patient needs individualized treatment, and the patient is also a member of that team, multidisciplinary group, which involves the radiologist, the pathologist, the radiation oncologist, the surgeon, the navigation nurse, and the oncology nurse. They make a decision not in terms of textbook description, but what they have seen, on this particular patient. Yes. And the patient has to ask genuine questions. Yeah. And also, before this patient gets treatment, as a doctor, what I like is to ask her to go for a second opinion, to ask another oncologist, and I would suggest, who do you go to give you another option? Yes. Is what I'm saying true? Is that all that there is?
Second opinion.
Yes. So second opinion, I think, is very, very important, because let the patient go, think over it, and go to another doctor who does the same work to give them advice, whether what Wasike is saying is true, or is favorable, or is good for her as an individual. So second opinion is crucial.
Great.
So if you have early breast cancer surgery up front, when the pathology report comes back, depending on the cancer subtype, for example, if it's ER/PR positive, then we might, in older patients, we may not do much. But in younger patients, it might be other factors might determine whether we give them chemo or not, but they require hormonal therapy for 5 years. But as I said, once you've done breast conservation, you must give them radiation to avoid recurrence. The other option is mastectomy. For example, even if it's stage 0, ductal carcinoma in situ, but it's a big size, or the patient prefers that since she has had this cancer, she wants her breast out, then we remove the breast. We do mastectomy.
Yeah.
What has helped patients in this time is what we call nipple-sparing mastectomy. So at the same time that we are doing the surgery, we remove only the breast tissue and we leave that skin with the nipple, and then we put implants or tissues from the patient. So that the patient goes with her normal breast. When she comes back, she has a new breast, okay? But the cancer has been removed. So nipple-sparing mastectomy is becoming very popular instead of the normal mastectomy.
All right.
Now, if it's local advanced stage 3, my preference, and people accuse me for behaving like a medical oncologist, is to give chemo up front, okay? Yeah. Because the potential for it to have gone elsewhere is very high, even if it has not settled, because they are circulating cancer cells in stage 3. So you want to give neoadjuvant chemotherapy, you send the patient first to the medical oncologist to give chemo, like 6 cycles, 8 cycles, once, and that way, usually, you will see the response of the tumor when it's still on the patient. Some of them completely disappear. And now the patient comes to ask you, what are you going to do surgery for what? Because there's no tumor, it has gone. So you have to explain to them what needs to be done. Now, stage 4 is no, it is gone everywhere. What we are focused on is on quality of life. We want to do things that are going to improve the quality of life of the patient.
You can't remove the breast.
You can if it is bleeding, if it has ulcerated and it's making the quality, and then the neighbors or the people who are taking care of the patient, the breast is stinking, then you can do what you call toilet mastectomy, just to avoid the bleeding, the smell, and the inconvenience to the patient and the caregivers.
All right. Now, Dr. we are notified that our time is almost up. Allow me to cut you short on that. As we wind up, I would like you to give us an umbrella of how breast cancer cases and where we are in terms of policy is in Kenya. And please talk about your book also, because I understand you've written a very wonderful book for the people, not for medical professionals, for the general public to understand the questions, so that the people can know about the book and where they can get it.
Okay. So in terms of numbers, and breast cancer is the commonest diagnosed cancer in this country at 15.5%, closely followed by cervical cancer at 13.3%, and then esophageal cancer, which is number 3 at 11.8%, then prostate cancer, which mainly affects men, at 10%, and the last one is colorectal cancer. Now, we get about 6,000 cases of breast cancer in Kenya every year.
Every year.
And 2,500 women die from it every year. The reason is they come late. They come in what those stages I was describing. They come in stage 3 and 4. Otherwise, routinely, breast cancer worldwide kills fewer people than any other cancer. The reason is because it is caught early and the treatments have really improved.
Screening.
Yes, that's why I still reinforce the fact that the importance of screening is there. Our government from 2020, when they recognized the value of cancer treatment in general, they started doing something. And as I already told you, the counties have facilities for screening, mammogram, ultrasound, not much MRI, but mammogram and ultrasound. And then they have also established treatment centers.
Treatment centers
within all
the
over
regions.
Karisa, there's radiation. Which came up, Mombasa, Kakamega, Kisii.
So people can access the service close to them.
Instead of coming all the way to Kenyatta or Nairobi. So that the government has done quite a bit of work. Then there's private-public partnership. So when a patient has, for example, the HER2 positive disease, they will use Herceptin, which is an
Please, let's talk about the book, because our time is up.
So I realized that when I see my patients with breast cancer, I don't have enough time. You know, I used to have 30 patients, 40 a day. So I decided I would write a book it's called Breast Cancer, What We All Need to Know. And it's simply from what it is up to treatment, the outcomes, social support groups, and all that. It's a small handbook, but the last chapter on revision is about cancer prevention. Chapter 17, which applies to all types of cancers. So that's about the book. It's available in my clinic at the Doctors Plaza in Aga Khan.
which the book is written for the general public,
It's
using
mainly,
the language
yes,
of the general public.
I don't know why you read a bit of it. What do you think? Is the language for the public?
It's for the public.
Yes.
It's not for medics.
Yes.
Thank you so much. So you can reach out. How can they reach out to you?
So usually I have a clinic at Doctors Plaza in Aga Khan. I work on Mondays and on Wednesdays. But my secretary is always there in room number 324.
Sure.
Thank you so much.
Thank you so much, Daktari. Maybe we'll have another time that we continue the conversation.
Yeah, we can talk about cancer prevention next time.
Yes.
Yeah, in general, instead of breast cancer.
Yes.
Yeah.
Thank you so much, every viewer that you've watched this show thus far. Our guest has been Dr. Wasike, who is a specialized general surgeon and a sub-specialized in breast cancer, what he calls oncoplasty, breast oncoplasty, right? Yes. Thank you so much. We really appreciate your time. We really appreciate the support. I've been your host, Dr. Chepsi, and for me, the summary, the take-home is that screening for breast cancer will play a very big role in preventing severe disease and also